As a few more people join, I'll walk through the agenda briefly. I'm so glad to see a few new faces on the phone today, and we welcome you to our Central Valley eConsults Coalition meeting. As you may know, we meet once a month. We are a group covering providers, payers, associations, and patient advocacy groups, and we're just so happy to see such a broad group on our call today. We'll let you introduce yourselves in just a moment. Today's agenda will include some updates on the activity that we're seeing across our program, a snapshot in terms of volume and activity to date. We are so happy to have a presenter from Connecticut Children's, Dr. Karen Rubin, who will be presenting her publication on pediatric e-consults. We'll talk a little bit about our dashboard for our program and share a bit about our featured program, another featured program that is relevant to May, which is National Mental Health Month, as you may know. So just so glad to have you on today. I'll give a quick overview since we do have some new people on our phone today. And as you may know, this is a collaborative effort. It's a very unique effort to promote e-consults across the Central Valley. This program is supported by Anthem Blue Cross, HealthNet, and Calviva. We're so glad to have our managed care plan supporting this program. It's a collaborative effort and welcome and open to all. So anyone who wants to join our calls, we welcome them. Anyone who's interested in promoting and encouraging the use of e-consult. We're really focused on access, trying to improve access across Fresno, Kings, Madera, and Tulare. We are growing. We started out with 6 FQs and now we're over 12 provider organizations along with supportive organizations across our counties. So I'd like, if you are on the webinar and you have access to chat, if you wouldn't mind just placing your name in our chat if you're new to today's call. We would love to be able to highlight you and welcome you and introduce you as part of our new group. So just in case you're wondering who is part of our group, here's a quick summary of our FQs who have gotten involved in the program. We've been around, I guess, since October last year, with clinics actively doing e-consults since 2020. So it's great to see more and more clinics launch every month. And you can see here in green those FQs who've been launched in multiple counties. And we have a few new clinics who we're glad to see are getting up and running and learning about our program and joining us. We hope to see them launched in 2021. So thanks for those of you who are introducing yourselves in chat right now. We welcome Dr. Naz from St. Agnes. Thank you so much for being on today. Steve Cade from Valley Children's, thanks for being here. And we encourage you to keep doing that, and I'll highlight those who are new to our call who join throughout the next few minutes or so. And as we move on here, just want to highlight what we've seen to date. This is great volume in terms of just engagement by our primary care providers, and we're just so surprised and happy to see early and active engagement in this program. So our clinics have done over 2,000 e-consults in 2021, which is so impressive. You can see here just a quick summary of the specialties that are covered or that have been covered as part of this program. This program is open to all specialties. However, you can see very high interest in certain specialties. And I'd love your thoughts here. I'd love to hear sort of if this matches your expectations with regard to referral volume, if the volume of e-consult you're seeing matches the demand and the need across our 4 counties. Any comments on that or questions?
Hi, this is Adnan Naz. Just a quick question on, have we done any investigation on what is the reason, let's say, suppose GI is the #1 consult, right? Do our providers actually believe that the e-consult is the way to go for this? Or do they understand or believe that it's difficult to refer one of their patients to a GI specialist?
That is a great question, Dr. Naz, and I'm going to offer the opportunity for Matt Miller to respond to that if you want to respond, Matt, but I'll just say initially, Family Healthcare Network has been engaged in the program for a good time now, and I know that there's a specific focus in doing e-consult for GI. Matt, I don't know if you want to comment on that? But you're on mute, so I'll let you think about if you have any comments, but I know that we have some clinics who've been doing this longer than others. we see across the country, national activity reflects a high amount of GIE consults. So I don't know if that helps with your question, Dr. Naz, but
Yeah.
Go ahead.
Yeah, no, and it does. I'm trying to build a case for our St. Agnes medical providers to use the tool. And while I did read the article that we had discussed earlier, you know, I think it's important for providers to understand that, right? Where is the value, you know, in using GI or cardiology or neurology, right? Everyone knows that in Fresno, there are cardiologists at every corner, you know, for better or for worse. So, you know, is the consult a better method, or is the in-person, you know, is in-person a better method? And most of our providers in town, you know, want to refer to somebody in person just so that they have that face-to-face interaction. And oftentimes, patients want that as well, right? So, you know, where is the clinical value versus the operational value is always something that as I think about when we present these to our provider groups.
That is a great question. And Darren, I'm going to let you speak to that in just a moment here. But I think what's interesting is when we look at sort of the top 10 that we see on this list here, it pretty closely matches what we see across the country in terms of active e-consult volume. But I think all specialties have the potential to be good e-consults, and I'm going to let an MD speak to that. So Darren, I don't know if you wanted to comment on that.
Yeah, no, I'd be happy to. Thanks, Libby and Dr. Naz. It's nice to meet you. I've been leading Confurban now for about 5 years, and we've seen you know, extensive use in pretty much all major medical and surgical specialties and subspecialties. And I think, you know, there's a lot of answers to your question. I think, you know, there are definitely many consults that are completely appropriate to go straight as a face-to-face visit. The patient wants it, the provider wants it. They need a specialty procedure. They have a relationship with somebody in town. They're following up after being seen in the hospital. But I think, you know, for every one of those types of consults, there's also the consults that we do when we're looking for an opinion, or, you know, second set of eyes on an unusual lab finding, or advice about the most appropriate next step, or perhaps suggestions for the next antihypertensive if the first 2 or 3 agents we've used haven't worked. And I think, you know, many primary care providers find, you know, as I have, that those types of consults can really be delivered effectively as an e-consult, and in so doing, you know, there's a variety of benefits to the system. You know, the driver for setting up e-consults originally was access. Most of our patients across the board have Medicaid, or many were uninsured, less now than it was in the past, and being able to get quick access to a specialist through an e-consult is great. The second reason is, as we're making the shift to more value-based reimbursement, you know, the fact that that doing an e-consult saves the system money and keeping patients from unnecessary visits that end up costing more. But I think there's also a benefit to the patients. I haven't met too many patients that relish the thought of taking a day off and, you know, in a federally qualified health center that's in their community, that speaks their language. You know, that obviously varies, but I think, you know, patients definitely derive some benefits from being able to get more of their care in primary care. So, you know, there's a range of reasons. And if you look, I'm always a little surprised that GI is the number one. And I think that's largely driven by difficult access. There certainly aren't the screening colonoscopies, but a lot of them, I look at a lot of the consults and the diagnoses, advice for refractory reflux, a lot of liver questions, hepatic steatosis, things like that are often managed well with an e-consult.
I realized my camera was off. So,
sorry, really quickly, I wanted to say Matt Miller from Family Healthcare Network. I think you were going to speak to to your GI use. Go ahead, Matt.
Yes, good afternoon. Can you all hear me?
Yes.
Okay, great. So I'm not a clinician, so I can't necessarily speak to that level. But what I can share is in the time that we've been doing e-consults, which has been the better part of, you know, over 2 years now, it's definitely a process that goes through refinement. At least that's what I've observed. As far as initially, we wanted to approach e-consults from just an all-encompassing perspective, GI, where we would pretty much channel all GI-based referrals for the most part through e-consults. But obviously, as we quickly found, there's going to be certain instances or circumstances where maybe that doesn't make the most sense in terms of efficiency or what's best for the patient. So we've definitely had to refine that process and working with our dedicated referral team and making determinations as to, okay, in what circumstances does it make sense to go the e-consult route versus not, and then develop those workflows and processes to adhere to that. So that's kind of been our experience as we've continued to work through the e-consult integration process and how we approach, how we route those referrals.
Thanks so much, Matt. And Delphine Tuo, who is one of our clinical advisors from UCSF and Zuckerberg SF General. Delphine, would you mind sharing your comment?
Sure, yeah, I just piggybacking off of others. Thank you for the opportunity. I just wanted to say that even for an in-person visit, an e-consult really allows that first in-person visit to be most effective, just to make sure that the pre-visit workup is complete. Because there's nothing more frustrating for either a patient or a specialist or any provider, I would say, if the patient comes and then you say, well, I can't answer your question or I can't determine next steps until I get X, Y, or Z diagnostic tests. And if that's recommended ahead of time, then that first visit becomes so much more efficient and as a result kind of improves patient satisfaction and improves the value of taking that time off of work to go to that in-person visit.
Thanks, Delphine. We appreciate your input. And I wanted to point out a couple of other great findings here. We look at this data every month, and we're really appreciative that ConfirmEd and Rubicon help us by providing the data that we see around ability to resolve referral requests without a face-to-face visit. So using e-consult to be able to most efficiently address the patient's need, as Darren mentioned, reducing travel and patient time off work. So it's great to see we're pretty steady month over month. We're around 80% resolution without face-to-face, which is a great, just a great number to be able to share. And, you know, far under 48 hours, or far under 24 hours, sorry to say that, way under 1 day in terms of specialist response time, which is just so impressive. And we are just glad to see this result of our work. Any other questions or comments?
No, I appreciate everyone's responses. A lot of the stuff you think about in your head, but you guys are the experts who have been doing this for some time now. So I'm really happy to hear a lot of those thoughts that we have as we try to present these here locally.
And it's really great to have the Q&A. So thanks for the discussion, Dr. Nas. With that, I think we'll probably delve into some more of these related topics with Dr. Rubin's presentation today. And Dr. Rubin, thank you so much for joining us. I'm going to ask Darren Anderson to introduce you. Darren, would you mind?
No, I'd really be incredibly pleased to do so. Dr. Rubin and I have known each other for over a decade. I first met her when I was practicing full-time in New Britain, Connecticut as a primary care provider, and she came to our office to tell us about a new tool that they were developing at Connecticut Children's Medical Center called CLASP tools, which were essentially really detailed, online accessible referral guidelines and workup outlines for some of the more comprehensive and complex conditions and common conditions that we were referring into CCMC. At the time we adopted them in our clinic. I'm an internist, so I didn't use them, but our pediatric providers did. And then we crossed paths several years later as we were looking to scale up our e-consult system in Connecticut, looking to expand into pediatrics. And Karen and I started working together with many of the other pediatric specialists in several pediatric subspecialties at CCMC to figure out how we could combine the best of what they had created with the CLASP tools and really integrate that with an e-consult platform so the idea was that primary care providers would have access to the online tools to help guide them in their workups, but they would be able to submit an e-consult if they had subsequent questions and wanted to get an opinion directly from the specialists themselves. And so Karen is here today to tell a little bit more about the results of the research that we did on this project, and we're excited. And Karen, I'm really grateful that you were able to take the time out of your busy day to join the meeting and to present on this. So thank you so much.
So Darren, turn on your video so I can see you. It's been a while.
Yeah, I'm on my phone, unfortunately.
Oh, you can. Okay, yeah. I thought I'd try. Well, thanks, Darren, and I really am. I'm delighted to be here to share our experience. So we actually got to collaborate together for about 3 years, And during that time, we decided to really develop a study design so we can actually see how we did and try to evaluate the impact of our collaboration. I do want to comment that I myself was an e-consult provider, so I have firsthand experience. And I want to comment again, just reiterate what I forget the name of the person who was talking about from the subspecialist side, how helpful it is that when you do see a patient who does require a face-to-face visit, it is a different ball. You're really starting out in a much better place, and it's a much more value added visit to have all the right information at the time of that visit. So e-consults and also integrating these tools that Darren mentioned, these co-management guidelines that are really the next evolution of guidelines that really includes a lot of support tools for the primary care. It's sort of an entire toolkit for that condition. So I'm gonna just review now, just dive into the study that we ended up doing. And if you could just go back to the study design page before we get, that would be great. So we decided to do a retrospective cohort study, and we compared patients referred to the 3 pediatric specialties that we were providing e-consults that were participating in Darren's e-consult platform. That's pediatric cardiology, pediatric endocrinology, and pulmonary. And the way we selected these was I begged everyone to participate, and I had relationships with more of the providers in these 3 subspecialties because this was something new. We hadn't participated in e-consults before. So we looked at the 10 months before the implementation and then the 10 months following the implementation. And the care pathway, we included where we had these CLASP tools available, we would include them if it was relevant to the e-consult question, we would include them as part of the response. I would never just include them, but I would refer to them because then there's a higher level of consistency and quality because these tools are expert or evidence-based tools. And there's a lot of support with, the hope was that if the primary care clinician would read them, that hopefully they wouldn't even have to come back for a similar e-consult question the next time because they would have this information at their bedside with them. So the data included patient demographics, the date of referral, appointment dates, e-consult response, outcomes, diagnosis codes, and we were able to utilize one of our star medical students who was graduating and in her 4th year actually was able to carve out time to do a lot of the work of this study, doing the electronic chart reviews, both at our tertiary center, Connecticut Children's in downtown Hartford, and also on the end of the federally qualified health centers. So I'm going to actually dive into now the tables now. So this just gives you, this is really the demographic table, and you can look at the gender, the ethnic race distribution, and the ages and the medical insurance. The only difference in the 2 groups was there was a slight increase of private insurance in the pre-intervention group. Next slide. Okay. So a big goal of this work is to improve access for this population. And the design here that we did was in pre-intervention. We had the 3 subspecialties here, as you can see on this table. And in each group, we had in the pre-intervention group, it's just the traditional face-to-face consults. It was before COVID. We weren't doing telehealth yet. Now the study would probably have another layer to it. And then we have the number of visits. As you know, it's one thing to schedule a visit. It's another thing for that family to actually come and complete that visit. So we felt it was very important to look at both, which we did both pre-intervention and post-intervention. And then on the post-intervention group, for the e-consult, this column is just the number of e-consults that were able to be managed within primary care and did not require a subsequent face-to-face visit. And then the face-to-face visits then are all the face-to-face visits, the ones that didn't go to e-consult initially and the ones that were recommended after an e-consult. And again, the completed is all that were completed. And then in the percent completed, if you, these are the patients that were seen face-to-face or had a e-consult not requiring face-to-face. Those were the percent completed. And as you can see in cardiology, if you look at the results, there was no we used t-test and chi-squared t-test, and there was no significant difference in terms of the percent completed between the pre-intervention and the post-intervention. Similarly in pulmonary, but in endocrinology, there was a statistically significant, and I can tell you for our practice, it's a clinically meaningful impact that we had. It was 54.5% versus 64.2% were completed in the post-intervention group where where they did have access to requesting an e-consult. Now, only 23%, although Darren made a heroic effort to educate all the federally qualified health centers about the availability and the purpose of the promise of e-consults, and through a number of grand rounds. And we also educated them about the CLASP tools as well. When it came down to it, at least in this 10 months after, 23% of all the referrals, only 23% were submitted for an e-consult. But once they were, in pediatrics, there is a difference because of the nature of, there's a difference between the percent that's felt to be safely managed within primary care in adults versus pediatrics. And it was very consistent throughout our 3 years. It was about 53% of the e-consults were able to prevent an unnecessary or a low value face-to-face visit. Next slide. And this is, I think, very interesting information, because this could really steer us to what tools are needed and where we might want to target developing some evidence-based materials to enhance the e-consult process. The other thing is, when you attach a tool, I can tell you as a provider, it shortens my e-consult response time in half. So it makes the whole process more efficient. So in cardiology, you can see heart murmur, chest pain, and palpitations. Now, before I even came to partner with Darren, we had taken the same approach. We had looked at all the referrals and targeted our tools to the top 30% of referrals in each pediatric subspecialty. So that was our goal, to try to get people from those faculty from those departments to work with us on developing those tools. In cardiology, before the partnership, we had the heart murmur one, but actually, based on what we were seeing in the e-consult questions, we actually were able to develop 2 more in cardiology for chest pain and palpitations. We already had syncope, and that was the 4th one, but we added 2 more really top reasons for referrals, and that was a result of this collaboration. In endocrinology, we similarly had, the short stature is the number 1, but that is a condition that I couldn't convince my group to give up that, because it's the way you measure, and it's so complex, the number of factors in that at least initial evaluation, that we weren't getting consensus internal consensus on developing that in our endocrine division. But for the others, we really had tools developed. And one of the ones in the overweight, the obesity comorbidities is increasingly a common cause for referral to endocrinology. And we were able to develop a very robust lipid abnormality protocol, in addition to other obesity comorbidities such as hypertension. So we had covered a lot of these for attachment. as well. And if you look at the Bs, the small Bs, you can see that at least 3 in 2 to 3 in each area had these tools, and they were in the top group of reasons for referral. In pulmonary, similarly, asthma and cough. I do want to comment that I think the numbers were the highest volume of referrals for e-consults was in endocrinology. And I think that, I'm not surprised we didn't see an impact in the others, because the volumes of referrals were much lower for e-consults. So I just wanted to comment on that. Next slide. We did very well. We were instructed as e-consult providers, responders, that we had that the goal was within 2 business days or 48 hours, that was the gold standard for e-consults. And I think all of us did very, very well. There were no differences. So this for us to do the e-consult completion. But when you look at in cardiology pre-intervention for the days to complete a referral versus post-intervention, in cardiology, actually, you were able to see you saw actually it took longer post-intervention. This is all the consults. This is not just e-consult. This is the e-consults and the face-to-face consults. So there's a lot of factors that could, confounding factors there. If you lose one clinician, as you know, all of a sudden your wait times for new consults are altered. And so there's so many other confounding variables. So it's hard for me to interpret the meaning of this. But again, I would say that the volume of e-consults to really decrease the days to completion of a consult just wasn't there in cardiology. We're in endocrinology, again, that impact shows through, and just like it did in the other table that I showed you. And in pulmonary, again, the volume was very low, and I'm not surprised. We didn't see that we saw any improvement. In cardiology, we saw a statistically significant worsening. So that's the data here. So in terms of the experience from an e-consult provider, and from my fellow e-consult providers at Connecticut Children's, it was really a good experience. And when the collaboration ended, I think there was expressed disappointment that they really felt that it was a good thing. They felt good about what they were doing and keeping children who had long wait times in their communities. So it was a very positive experience from the specialist side. And again, when we would see these patients, we would have a lot of documentation and a lot of information available to us. So the system clearly is, you're all champions, so I'm preaching to the choir. And I think the problem with now that we're not collaborating with Darren, for our institution is, how do you incentivize participation? Specialists are getting report cards every day. I mean, not every day, but every week or every month on their RVUs or their volumes, their volume targets. So what this incentives will need to be built in for the time that it takes for specialists to provide e-consults. And similarly, on the primary care side, they have to tee up the information and really articulate a clear question or concern and attach the supporting health information. So it's really, I think, as we go towards value-based care and we're paid differently, I think it's going to work itself out. I think that might be it.
Yes, that was such a great summary there, Dr. Rubin, and you sort of teed up our next conversation, which is around engaging specialists. But if you have a few minutes, we'd love to have a little bit of a Q&A. Is that okay?
Yeah.
Great. So my first question, actually, I'm going to go back to this slide that, or this data point that you had around with certain consults having less of a median time to closure. So 1 day for cardiology, less than 24 hours for endocrine, and 3 days for pulmonology. Is that, do you have any idea, is that perhaps because there's more of a back and forth between the primary care and the specialists for certain specialties, or do you have any idea why that might be?
For the e-consult, no, we actually had, that's a good question. We actually had a few consults where we went back to Darren's team and requested that we needed to have we would respond to the first e-consult, but we would ask for more information. And then we were able to get that information and have a second consult. I think the difference is just who's on call and how busy, the difference, it was the volume of e-consults was less in cardiology, and we had just more compulsive providers there, e-consult responders, that they were really good at responding right away. In endocrine, but I think one day in less than 24 hours for endocrinology. Pulmonary, I can tell you, I know the culture in pulmonary, so I'm not surprised that they were the slackers.
And that's not a slack. That's not being a slacker. If it's 3 days, it's far better wait time than normal. So.
Yeah, but I think we really wanted to be respectful that the primary care doctors are waiting to get back to their patients and make a resolution on their case. So I think for routine, we tried to make it 48 hours. There were sometimes, I don't want to go into the weeds, where our system, it didn't get to the right person, right? So again, it's very important on the specialist side to know who's responsible for picking up the consults each day. It's almost like an e-consult on-call process. And we left each division to do it on its own, but so that some had better structure than others. That's another point I want to make.
That's really helpful, Dr. Rubin. I think through the programs, or through this program, I think that the platforms that our FQs are using take that out of the equation, and that the request is automatically routed to the first available provider. So that's taken out of the.
That's great.
Okay. But you bring up good points around incentives and specialist payment that we're tackling also in California.
Great.
I want to open up for Dr. Rubin to respond to any questions we have from you all. So you can either unmute yourself or you can use chat to share a question with Dr. Rubin. Any questions?
So Dr. Rubin, this is Steve Cade here from Valley Children's Hospital. First of all, congratulations on all the work you've done. It's a tremendous task and blazed a trail. We're at the other end. We're just starting out on this journey. We're excited as an organization to start the consults after some kind of evaluation. Very enthusiastic response on behalf of our physicians and the leadership as well. My question is, you mentioned the benefit of the toolkits that you had provided and developed. Have you got any suggestions how we might go about that as an adjunct to doing the e-consults? It seems from what you're saying that the toolkit and the kind of the pathways or guidelines, the evidence-based medicine approach to educating as well is a key part of that. You got any advice for us?
Yes, I do actually. A lot goes in. Our methodology is as I said, we target the common conditions, because it'll come up so much that the primary care doctor, it'll get wired into their DNA. They will really take it on and incorporate it into their scope of work. So the idea is that the milder complexity, acuity conditions, they keep within primary care. And then the specialists really have time from the moderate to high complexity conditions, and really are able to see those patients and have enough touch points with those patients, and also have access for more new patients that really need to be seen by a specialist. So the advice to you, our method, we really co-develop it. We really co-develop it. We have an infrastructure for these tools where we have a clinically integrated network now that we work very closely with. And before that, we had a similar referring provider advisory group where they prioritize what their needs are, and we have them involved all early on in the co-development. Some of our tools, as you can imagine, involve more than one specialist, especially in conditions where there's behavior-based aspects. And some of these tools have taken, because it's, this is an add-on on the specialist time. They really they take way too long to develop some of these tools because it's on their discretionary time. But we've put a lot into this, and now we've developed a methodology to get them developed quicker and set timelines. And we have a woman who does all the formatting, and I really I have them look at the other tools. And in the beginning, we said, what's your goal with this tool? What are you really trying to accomplish? And then what are the support tools and the medication sheets and all the guides that the PCPs are going to need? And the PCPs are there to tell us. And we get that first draft and we bring it to our vetting team, and then we're really get some more feedback. It takes a few times back and forth, and we're there. But it's not simple. So what I'm telling you is we have developed a licensing schedule for this content for different institutes, different healthcare organizations that are starting to move towards value-based care, that we could actually lend you the content. You can adapt it to your workforce. And the fee schedule that I developed with Darren is based on your pediatric covered lives and also the content. So if you get one specialty and 3 plans for which would, as I said, it could cover about 30% of referrals in that area. That's the way we developed it. So that's that. If you can develop it on your own, but what I'm telling you, it's going to take a long time. We've been doing this for 12 years. We have about 40 toolkits developed. And I would say about 20 to 30 of them are really powerful and really, really polished, because we got better at this as we went along. We also have updates every 2 years where it's very systematic, where we go back to the authors, or if a new guideline appears before them, we go back and we update them, and they're very nimble. I can send you examples of what they look like, but they're bullet points. The only narrative piece is just in the background section at the top, and the attachments are really handouts for the families. So for a headache, it would be a headache diary. It would be behavioral tips for headache management for the family. And for the provider, it would be the first line medications. If you're not going to respond to the first line medications, we have them see the patients back, for example, in 6 weeks. And if there's no improvement and we define what improvement is, then they refer. We're very specific, because this is we want to make it streamlined and easy for the primary care provider to use. So I'll pause now if that gives you an idea.
Yeah, absolutely. I'd love to follow up with you on, we would be very interested in accessing through your licensing arrangement.
Thank you, Dr. Rubin, for these examples, and we'd love to be able to share them as part of our monthly work group calls. These tools sound wonderful. We also have our econsultworkgroup.com playbook, which includes some Connecticut examples. They might reference your program too. And what I'd love, Steve, is perhaps you have some observations on how this might apply back to the Central Valley. Do you think that these examples are relevant? Do they mirror what we might see in terms of
population
consult impact on the Central Valley, the pediatrics?
Yes, I see a very close correlation between them. Part of the challenge we have here in the Central Valley is we cover like a 45,000 square miles, so a lot of patients outside of the Central Valley are over 2 hours away. So you've got the travel component, which also impacts the access. So yeah, and I very much think that having the tools to provide education is exactly what we want, because we're absolutely aligned in that we want to make sure that kids that can be seen in the pediatric setting where they live at home, probably 2 hours from here, can be seen there. And those that need to travel, when they do get here, they can get an appointment all the sooner because the volume's less. So yeah, this is a great presentation. I look forward to following up with you, Dr. Rubin, and thanks again for all the hard work that you and your team have put into this. So.
Thank you, Dr. Rubin. We appreciate your time today, and it's we're so lucky that we have your 10 or more years of eConsult experience to be able to tap into, and we welcome you. And of course, if you'd like to join our future calls, we'd love to have you. So
yeah, and I just want to thank Darren for giving us the opportunity to participate in a really wonderful platform and very important goals for this population.
thanks again.
Okay, thanks. Great speaking with you.
Thank you. I think this slide really reiterates what Dr. Rubin shared as part of how to get a program up and running, noting that we do need to provide support for our primary care teams. Our goals of our program are that our primary care providers and referral teams will think about this as a first step for a routine, non-urgent or non-procedural referral. So we know that our PCPs have the relationship with the patients. We know that they can make those decisions. We appreciate our vendors' support of the referral processes of our FQs. So that's helpful. And Dr. Rubin brought up the need to be able to support the primary care provider's time. eConsult, as you know, if you're new to our group, is available to all of our FQs for all Medi-Cal patients, and that's thanks to our plans, thanks to our managed care plans who are joining us today. We know that all primary care providers may not be participating in eConsult because they have different roles, but we would like all referring providers to have that chance to be able to participate, and that's why we're here, to support that and help your FQs to get up and running in any way we can. And another part of our role here as a coalition is to look to our local specialists and encourage them to get involved in our program. We're so lucky we have our vendor platforms and remote panelists, our Medi-Cal enrolled California licensed providers who are responding to eConsults, but we also want to build our local relationships. Thank you, Steve, for joining us today from Valley Children's and ChildNet. And really want to be able to convey between you, primary care providers, and your specialist referral partners that eConsult is a potential revenue stream for them. It is a part of your referral process. We want them to be able to participate in that and build that community. I think Dr. Rubin, Dr. Tuo, and Dr. Anderson conveyed that we're making this easier on the patient. That's our goal, to reduce the patient travel and time away from work, reduce unnecessary face-to-face visits if their issues can be resolved remotely, and reduce duplication in diagnostics, et cetera, and really make the best use of our specialist network, since they are limited, as we all know. Dr. Rubin, this note at the bottom of our slide here shows that we do have, through Medi-Cal, a CPT code for specialist time for eConsults, and we're working on primary care too. So we're working to eventually see primary care providers also reimbursed for their time. I know that might be a process that we might take some more time to be able to complete, and we'll talk about that just a minute here. But we want to take some time to think about how we're looking at those primary care provider goals and those specialty goals and documenting them as a coalition. So as we've talked about on our past few calls, we're developing a dashboard. Thank you to ConfirmEd, to the payers, and to the IPAs for contributing to this, to be able to have a big picture view of what's happening across our 4 counties. John, do you want to speak to this?
Sure. Yeah, thanks, Libby. And as Libby mentions, really what our goal here is we know that each of the eConsult providers are offering dashboards into each individual group's capabilities on a month-over-month basis. But what we're looking to do is really kind of take pieces of that information and make it into more of a community view that's really focused, continues the focus around access, cost of care, efficiencies, and quality. And so these are some of the metrics that we're starting to look at. And really our goal is to look at how do we kind of leverage that information to keep building utilization, ensuring that there's high value from the services that are being offered. And then how do we use that data to then identify levers and areas of opportunity to continue to enhance the utilization of eConsult. To Steve Cade's earlier point, for example, what's the impact on reduction of travel and for patients who generally may have to come 2 hours to get to a visit? What's the impact of not having to do that, and what's the scale of it as well? And so some of these you'll be familiar with, based on what the eConsult vendors are providing on an ongoing basis. but we're also looking to work also with the clinics, the IPAs, and the health plans to pull in other components that can then enhance that information in various ways, and kind of look at certain dollars and cents aspects, and also look at how do we continue to build out the program based on where it is today and where we want to take it. So the last two metrics down here, for example, is we'll kind of track on active clinics, active users within those clinics, and also how do we get our specialist panels within the region more engaged, and to further work around that. So I'm open to questions around this, but ultimately, if we haven't already outreached to you to discuss data, how it may be used, and what needs we might have as we think about a community-based dashboard, we'll be doing so, and look forward to speaking with different organizations around that, and thinking about how these dashboards can help impact the community based on creating action-focused data. Thanks, Libby.
Thanks, John. If you have any questions or comments on what data we're capturing, please do share them, and we'll make sure to consider as we do this data gathering and share our next version of our dashboard on our next month's call. So Dr. Rubin brought up the point of needing to consider how we provide incentives for our PCPs and specialists in eConsult in order to encourage engagement. So we've updated you on the past few calls that we have been tracking State Bill 365 from Senator Ana Caballero. And we were so pleased that in March this passed through Senate Health unanimously. They went to appropriations yesterday, is in suspense right now, but this we've heard positive thoughts from Senate Health that this is going to be revisited in June, and we'll keep you posted. We just wanted you to know that we're tracking this, and this is one of our priorities to make sure we're addressing both primary care and specialist needs for acknowledgement of their time and commitment. I wanted to point you back. I mentioned that we've been gathering tools. Connecticut is a great contributor, and we have programs across the country that we look to best practices, and want you to know that these are all captured on our econsultworkgroup.com website. In addition, we have econsultworkgroup.com Fresno, which has our coalition materials. So our Central Valley eConsult coalition materials you can find there too. And with that, we wanted to acknowledge that the fact that May is Mental Health Awareness Month. And with that, we have focused our next eConsult workgroup call, which is May 26th, on eConsult and mental health. So e-referral and eConsult to integrate primary care and mental health. We've talked a bit about LA. It's probably the longest standing program in California. And we wanted to share their examples of how they have integrated eConsult for mental health. So please join us next week. Mark your calendars for May 26th, 11 a.m. And we'll make sure that you have this Zoom link. This is actually in your email too, so you can refer back to this if you'd like to join us next week. And also want to acknowledge that with May being Mental Health Awareness Month, we wanted to revisit what we presented last month on the CAP Child Psych Access Program. And I believe, Michelle, are you on?
Hi there. Hi,
Great.
Libby.
Michelle, would you mind introducing yourself and just recapping the program for us and the opportunity for clinics?
Absolutely. Thank you for having us on the call. So I'm Michelle Reeder. I'm a child and adolescent psychiatrist at UCSF, and I am one of the associate directors of our Child Psychiatry Access Program, which is called CAP. It's the Child and Adolescent Psychiatry Portal. Also on the call here today is Petra Stambushel, who's the director of our program. And a couple of weeks ago, we were able to talk about our program. We are a philanthropically funded consultation program that provides real-time telephone consultation between primary care providers and child psychiatrists, all of whom are at UCSF. And we launched in 2019 and have been expanding across parts of Northern California, and are very interested in continuing our expansion and offering our services to practices in the Central Valley. And just wanted to take a moment today to highlight how to get involved and how to enroll in the program. It's a really simple process, and basically consists of two steps. One is to complete our enrollment form, and I believe Libby has shared a brochure with the invitation today that also has the link to our enrollment form.
And I'll put that in the chat. Thanks, Michelle. It's on this slide, but I'll make sure they have the detail. Thanks.
Perfect. Thank you. And then after we collect some information from that enrollment form, basically it's just information about your individual networks or practices, including, how many practices are, are part of your network, the number of providers, the different specialties of providers, and the, types of patients and demographics that you serve. After that, we'll reach out to you and schedule basically what we call an enrollment meeting, which is really an informal meeting via Zoom where we talk about our service and explain to frontline providers how they are able to call a CAP consult. So it's quite simple, just 2 steps: filling out this enrollment form and then meeting on Zoom for the enrollment meeting. And then after that, we're able to consider your practice enrolled, and all of your providers in your practice will be able to, get on the phone and do a real-time consultation at any time that they think it would be necessary with one of our child psychiatrists. In hearing sort of the wonderful presentations today, I think there's a lot of shared goals that our program has with sort of the e-consult model. And even though our consultation is via telephone, I think a lot of the benefits, including improved access to care for patients, really kind of harnessing and utilizing that provider relationship that already exists between primary care and patients and families, and really acknowledging, particularly in the behavioral health world, the limited access to specialty mental health care, that we're really hoping to bridge some of those gaps and really help to provide access. So happy to answer any questions, comments, and you can see here my email is provided, so please feel free to reach out to me via email. I would love to talk and help you to enroll your FQ or your practice with us. Thank you.
Thank you, Dr. Reeder. And just want to note the CAP enrollment form is in the chat here. I'll also put Dr. Reeder's email address so you have that. It's also in your email. You received it this morning. And thank you, Dr. Steinbushel, for joining us too. Really appreciate that. Any questions from the group for our CAP team? Okay. With that, I'll open up for any final announcements before we wrap up. Please use the chat if you have any questions or comments that you'd like to share with our group. And with that, we just want to reiterate that we'll be meeting every month to gather together, share some of those tools that we have developed as part of our coalition, as part of our work group. We're asking our FQ partners to share their examples, their successes, highlight users who deserve a little bit of recognition, since we know our primary care and referral teams are really integral to making this work. And we just thank you for your time and your commitment to this program. Thanks for letting us know if you have any questions. I'll leave the chat up so you can get that CAP enrollment form if you need it, and I'll place Dr. Reeder's email address in the chat too. Thanks for your time today.
Thank you.
Thank you, Libby.
Thanks.